Assalamu alaikum. Welcome to our second session of free papers here at 19th Shaukat Khanum Cancer Symposium. We've got some exciting papers which will be presented by our distinguished presenters. Our first presentation is Surgical Outcomes of Adrenal Masses by Dr. Danish Masood from Shaukat Khanum Memorial Cancer Hospital and Research Center. Over to Dr. Danish Masood.
Assalamu alaikum. Good morning, everybody. I'm Dr. Danish Masood, surgery resident working at Shaukat Khanum Memorial Cancer Hospital. The topic for my presentation is surgical outcomes of adrenal masses, study from our center. Speaking about adrenal cancers, they affect 3 to 10% of the human population, and the median age of diagnosis is in the 5th to the 6th decade of life. Adrenal tumors are classified according to the region they involve, which includes adrenocortical tumors, adrenomedullary tumors. Adrenocortical tumors are further subclassified on the basis of the severity. Like if they're benign, then adrenocortical adenoma or nodular hyperplasia, and the malignant ones contain adrenocortical carcinomas. The medullary tumors are pheochromocytoma if they are benign. And if they are malignant, there are neuroblastomas. And there are certain rare cancers like myelolipoma and adrenal mets as well. How do we diagnose them? The diagnosis is based upon history and clinical examination along with biochemical and radiological grounds. Patient usually presents with, if they have functional tumors, they might present with the hormonal excess symptoms like virilization, feminization syndromes. If there are non-functional tumors, then local tumor mass effects will be there, like abdominal fullness, flank pain, fever, weight loss. Biochemically, we can confirm these tumors by calculating the 24-hour urinary or plasma cortisol levels if the tumor is glucocorticoid secreting. If it is mineralocorticoid secreting, then we check plasma renin to aldosterone ratio. If the tumors are secreting androgens, then certain androgens like 17-hydroxyprogesterone, DHEA, and testosterone levels are checked. For a few pheochromocytomas, metanephrine and normetanephrine levels are calculated. Radiologically, CT and MRI remain the first choice of investigations. And if biochemically the tumor is not diagnosed, but there are symptoms, then MIBG scan is recommended. And PET-CT is for those tumors who which recur or who have metastases. We approach these tumors depending on the size and functionality. If the tumors are less than 6 centimeters and they are non-functional, then yearly hormonal evaluation with endocrinology follow-up for 5 years is recommended. And if that tumor is functional, then of course surgery would be opted. Surgically, we have open and minimally invasive techniques. Minimally invasive techniques involves laparoscopic and robotic surgeries. For masses which are greater than 6 centimeters and are non-functional with no high-risk findings, like washout less than 10% and HU greater than 10, then of course repeat imaging will be done in 3 to 6 months. If there is no change in size, then a yearly CT for 2 years and further follow-up for 5 years is recommended. If the tumors greater than 6 centimeters have high risk findings like washout less than 10% in HU greater than 10, then of course surgery would be opted. Coming to my study, it's a retrospective study which was done on patients with age more than 18 years from January 2009 to July 2019. Statistical analysis was performed using the SPSS software version 20. Coming to the results, total of 39 patients were included in my study, of which there was female predominance. Talking about the tumor, most of the tumors were functional, benign, with the left laterality and clinical and pathological stage of 2. Patients presented, most of the patients were symptomatic on at the time of presentation, and on follow-up, the patients had less recurrence, less metastases, and the disease-related mortality was minimal. So the overall 5-year survival was 59% from this study. Surgery is the cornerstone in the management that improve both survival and symptomatic relief in functioning adrenal tumors. incidental diagnosis and early presentation of adrenal masses showed better survival. That's all about my study. Thank you.
Thank you, Dr. Danish. Excellent presentation. Our next speaker is Dr. Shameen Ikram, again from Shaukat Khanum Memorial Cancer Hospital, and she'll be talking about comparative effects of perioperative and adjuvant chemotherapy and outcomes of operable gastric cancer. So, Dr. Shameen, over to you.
Assalamu alaikum. Bismillahirrahmanirrahim. My name is Shameen Ikram and I'm a clinical pharmacist at Shaukat Khanum Hospital, Peshawar. Okay, so my research topic is going to be the comparative effects of, let me start my slide. My research topic is going to be the comparative effect of perioperative chemotherapy and adjuvant chemotherapy on outcomes of operable gastric cancer. As gastric cancer is the third leading cause of cancer death worldwide, and in Pakistan, approximately 4,000 new cases are diagnosed every year with gastric cancer. And this lethal cancer causes 1 in 12 of all cancer-related deaths. As we already know, perioperative chemotherapy is a chemotherapy given around the time of surgery, that is preoperatively and postoperatively. While on the other hand, adjuvant chemotherapy is given post-surgical resection. The objective of our study was to assess the impact of perioperative chemotherapy versus adjuvant chemotherapy on survival of operable gastric cancer. Our study was a retrospective study, and the data was collected through hospital information system from the year 2015 till 2019. A total of 512 patients were registered over that period, and 96 patients were available after final analysis. We included all those patients who had histologically proven gastric adenocarcinoma and operable disease at the time of surgery, and excluded all those patients who had TIS, T1, and not disease, inoperable and metastatic disease, and who had incomplete chemotherapy, and those patients who had inadequate lymphadenectomy, that is less than D2 lymphadenectomy. So we excluded all those patients. In operational definitions, the overall survival was defined as the length of time from the date of diagnosis till last follow-up or death, while the disease-free survival was defined as the length of time from the date of treatment till progression, tumor relapse, or death. Median was defined as the point at which 50% of the population had not encountered any kind of event. It could have been a life or death in case of overall survival, or progression in case of disease-free survival. Our patient population was categorized in two groups according to the treatment. In arm A, we had 71 patients who had perioperative chemotherapy. In arm B, we had 25 patients who had adjuvant chemotherapy. In clinical characteristics of our patients, the patient who received adjuvant chemotherapy, the median age was 48 years, and all those 15 were male, while 10 were female. In case of perioperative chemotherapy, the median age was 51 years, 50 were male, and 21 were female. Now coming towards our results, the perioperative chemotherapy, the median overall survival was 49 months, while in adjuvant chemotherapy, the median overall survival was 28 months. On the other hand, the median disease-free survival was 38 months, while in case of adjuvant chemotherapy, it was 14 months. Coming towards the 2-year and 3-year overall survival probability, for perioperative chemotherapy, the 2-year overall survival probability was 68%, while in case of adjuvant chemotherapy, the 2-year overall survival probability was 60%. The 3-year overall survival probability was 58% for perioperative chemotherapy, while in case of adjuvant chemotherapy, the 3-year overall survival was 48%. This is the Kaplan-Meier survival curve. As we can see, our p-value was not statistically significant. It was less than it was more than 0.05. It was not statistically significant. And at 24 months, if we look at the graph, so at 24 months, there is clinical difference between the two arms. The green represents the perioperative chemotherapy, while the blue represents the adjuvant chemotherapy. So yes, we can see in overall survival, if we don't have statistically significant difference, but we had a clinical difference between the two arms. Now moving on to the 2-year and 3-year disease-free survival between the two arms. In case of perioperative chemotherapy, the 2-year DFS was 56%, while in case of adjuvant chemotherapy, it was 44%. The 3-year disease-free survival was 50%, while in case of perioperative chemotherapy arm, while the 3-year disease-free survival for adjuvant chemotherapy was not achieved, as our patient didn't reach the 3-year endpoint. This is again the survival curve analysis for the DFS, Kaplan-Meier. The p-value was significant. It was more than 0.05. It was not statistically significant, but clinically at 24 months, we had a clinical difference between these two arms. And perioperative had a benefit over the adjuvant chemotherapy. So yeah, we can conclude at this point that our study supports the use of perioperative chemotherapy for operable gastric cancer. But the results were not statistically significant, but we were able to see a clinical difference between these two arms. Thank you.
I'm Dr. Mikul Suman. I have a question. Very good presentation, Miss Shamin.
Thank you,
So
ma'am.
I would say that the results are not significant because the two arms were not very well balanced. The post-op or
Yes,
the
ma'am.
adjuvant treatment arm had, I mean, 1/3 of the patients as compared to the perioperative. And did you notice any difference between the two perioperative regimes? Did you look for that as well?
No, ma'am, we didn't analyze that.
Any data?
It
How
was
many
just on
patients?
the modality based.
Okay. So
No, ma'am,
any
we didn't analyze these things.
so you have no idea how many patients were on magic trial and how many had the flot regime
No,
in the
no,
perioperative
ma'am. We
setting?
didn't analyze on the basis of yes, ma'am. We didn't analyze it on the basis of the chemotherapy regime. We only analyzed this over the chemotherapy modalities, like adjuvant chemotherapy given or perioperatively given.
So I would suggest do that as well. It was a very good study although.
Thank you, ma'am.
Thank you, Dr. Shami. So we'll move on to our next speaker. It's Dr. Verda Beg, again from Shaukat Khanum Hospital, and she'll be talking about cutaneous malignant melanoma, clinicopathological factors and outcomes. So, Dr. Verda Beg.
Assalamu alaikum and good morning, everyone. I am Dr. Varda Beg, Resident General Surgery here at Shaukat Khanum Hospital, Lahore. And my research is about the clinicopathological characteristics and short-term survival analysis of cutaneous malignant melanoma. So we decided to go for this study because it's an uncommon entity, cutaneous malignant melanoma, and we found some gaps in international publications specifically regarding the data in South Asian population. So I'm here to highlight the features of cutaneous malignant melanoma as we found in our study, specifically in the South Asian population who came at Shaukat Khanum Hospital. And I hope it would understand the disease patterns and help us to make an early diagnosis and manage these patients in a better. So the research design and methodology, it was a cross-sectional retrospective review of patients who presented to Shaukat Khanum Hospital, Lahore from 2014 to 2017. The data that we collected was analyzed on SPSS statistic version 21. We found out in the 28 patients who were enrolled in the study was the mean age was a little lower than expected. It was 46.5 plus minus 15 years, and most of the cases, most of the patients were in their 4th and 5th decade of life. 7.1% of the patients, they had a positive family history for malignant melanoma. Our study had 57% of male population and 42% of female population. What's interesting was the demographics. We found that 50% of our patients hailed from the Khyber Pakhtunkhwa region of Pakistan and 40% from the Punjab province, 10% from Afghanistan. Now, here I would like to highlight some of the risk factors associated with malignant melanoma. Light-skinned people having increased exposure of UV radiations, and those who have a positive family history, they are at increased risk of developing this malady. The location for malignant melanoma, we found that lower limb was the most common part of the body affected, with head and neck and upper limb sharing the second spot, and it was uncommon to find malignant melanoma in the trunk. Histopathological analysis was done, and we found that 75% of the tumors belonged to unclassified variety. 21% of the lesions, they were nodular, 3.5% were superficial spreading, and there was an alarming finding that 61% of the patients were already at stage T4 when they presented with their symptoms. Later on, after treatment, 50% of the patients went on to develop metastatic lesions, that too most commonly in the lungs. This is a graphical representation of the nodular lesion, and this one here is showing a superficial spreading melanoma. So to briefly talk about the clock levels that we use to define malignant melanomas, the level 1 tumors, they are in situ, they remain within the epidermis. The level 2 malignant melanomas, they are just about to enter the dermis by crossing the basement membrane. Level 3 are the ones that have already entered the papillary layer of dermis. Level 4 are in the reticular layer of the dermis, and level 5 go on to invade the subcutaneous tissues. In our study, we found that Clark level 4 was the most common one. However, data from a large population of our patients was missing. Level 1, 2, and 3 were not commonly found. Here again, we see that level 4, which is a deeper invasion of a tumor, was the presenting complaint, which means that more often than not, we are failing to recognize the cancer at an early stage. So all the patients, they were treated according to their staging and grading. And after treatment, surgical treatments, and in some cases, palliative radiation, we found that local recurrence was present in 60% of the patients. This recurrence was found predominantly in the locoregional lymph nodes. Then again, as I said before, that 50% of the patients, they developed metastasis, and the mean disease-free survival was only 9 months, plus or minus 5 months. A dismal finding, the mean overall survival was only 13 months. Here's a representation of the distant mets that we found in our patients, which were most of the times diagnosed on CT scan or bone scans. So if I talk about the limitations of my study, this was a retrospective study, and we failed to enroll a large number of patients. So with only 28 patients, I cannot with confidence say that my data is a very accurate representation of the demographics, or the results are very accurate. However, since cutaneous malignant melanoma is an aggressive disease and it has a low mean survival, early recognition is the key to better patient outcomes. So for the patients, what we can do is we enable ourselves and become adept at identifying suspicious looking lesions. We recognize the patients at risk, especially those who are living at high altitudes, light skin, light hair, light eyes, and we encourage the masses to adopt risk reducing behaviors. Thank you so much. I would especially like to convey my gratitude to the organizing committee for continuing education and making it a priority in times of COVID. If there are any questions, I'm ready to take them.
I'm Usman. I'm one of the hosts. I've got a
Yes,
question for you.
Yes,
So,
sir, sure.
are the all cases were like stage 1? Like, what was the stage of all these patients when they came?
Sir, 60% of the patients were already at T4 stage. And histologically, that's it. Like T4 was the stage at presentation of 60% of the patients.
And have you looked at the outcomes on the basis of their initial staging, like early stage versus advanced stage and things like that? So, because your
No,
outcome is
sir,
very kind of.
that was not the objective of my study. We were just looking at, retrospectively looking at the patients who presented, and we saw what happened to them. We just followed the cases. However, there was this one finding that surgery alone led to a larger amount of patients developing locoregional recurrence, and if we combined it with the palliative radiation, it reduces the recurrence rate, but not significantly. So I didn't include that part in the study.
I have a question, Dr. Varda.
Yes.
Sentinel lymph node biopsy, was it done in your patients? I know it's a retrospective analysis.
No, ma'am. No, it was not done in my study, in my patients. Sorry.
Okay, thank you, Dr. Verda. So our next participant is Dr. Aisha Rahat from, again, Shaukat Khan Memorial Cancer Hospital, and she'll be talking about the clinicopathologic characteristics and outcomes of neuroendocrine tumors.
Assalamu alaikum. Thank you so much, Dr. Usman. Bismillahirrahmanirrahim. I am Dr. Aisha Rahat, working as a medical officer in Medical Oncology Department, Shaukat Khanum Hospital, Peshawar, and I am here to present my research paper on the clinicopathological characteristics and outcomes of gastroenteropancreatic neuroendocrine tumors. As we know, neuroendocrine tumors consist of a broad spectrum of malignancies that arise from neuroendocrine cells throughout the body. They are a heterogeneous group of epithelial neoplastic growths with variable behaviors and consequences. Majority arise in the gastrointestinal tract, and collectively they are referred to as JEPNETs. They include carcinoid tumors, pancreatic islet cell tumors, insulinomas, gastrinomas, glucagonomas, VIPomas, and somatostatinomas. Although there has been a worldwide increase in the prevalence of JEPNETs, there have been very few studies, to the best of our knowledge, in Pakistan to fully understand the clinicopathological characteristics of this rare tumor. Despite their diversity in tissue of origin, the management of JEPNETs are guided by various clinical and pathological features related to tumor grade, presence of metastasis, and tumor resectability. Some JEPNETs may also occur in the context of familial syndromes. Approximately 10% are associated with MEN1 syndrome, but they can also be found in neurofibromatosis type 1, von Hippel-Lindau disease, tuberous sclerosis, and occasionally familial adenomatous polyposis. Now, coming towards the objective of our study, which was to determine the clinicopathological characteristics, the overall survival and disease-free survival on the basis of tumor resectability, tumor grade, and resectability. The methodology that was used was that it was a retrospective study in which data was collected via the computer-based hospital information system, and patients were selected from January 2006 to August 2019. We only selected patients who were histologically diagnosed with primary JEPNETs that were classified according to the WHO classification of 2010, dividing them into 3 grades on the basis of Ki67 and mitotic count. Those having a mitotic count and Ki67 less than 2 were considered low grade, between 2 to 20 were considered intermediate grade, and greater than 20 were taken as high grade. We excluded patients with dual histologies and extra JEPNETs. A total of 444 patients were registered in Shaukat Khanum Memorial Trust during this period, and 134 patients were available for final analysis. Overall survival was estimated using Kaplan-Meier curves, and log rank test was used to estimate the statistical difference between groups. Now, coming towards the results, there were more males than females. 57.5% males were there. Majority of our patients were low grade, that is 59%, and most of our patients had localized disease. Almost 27% of our patients had metastatic disease at presentation. In our entire study, only 3 patients were found to be associated with MEN1 syndrome, making it a total of 2.2%, whereas all others were sporadic. 15.6% patients presented with NET-related symptoms, for example, diarrhea, facial flushing, and abdominal pain, while 77.6% patients presented with symptoms related to localized disease, for example, PR bleed, dysphagia, etc. Most common site of primary tumor was found to be the pancreas, whereas the least common site was the liver. Liver was also found to be the most common site for metastasis. Now, there is a general consensus that surgery is a primary treatment option in case of limited disease. We had 3 arms: completely resected patients, incompletely resected patients, and unresected patients. Only 2 people died in the completely resected group, making the overall survival to be 95.1%. As you can see in this Kaplan-Meier graph, the difference between the overall survival of the unresected and completely resected and the unresected and the partially resected was significant, as opposed to the arm with completely resected and partially resected group. Patients in the unresected group were able to achieve a median survival of 23 months, but completely and partially resected patients were not able to achieve a median survival, as more than 50% of patients were alive at the time of study. This chart shows the 5-year overall survival probability with completely resected patients at the top. Now, the endpoint in DFS was disease progression or death after completion of surgery. 5 patients died in the completely resected arm, and 9 patients died in the partially resected arm. Patients in both arms did not achieve a median disease-free survival, as more than 50% were alive at the time of study. 5-year disease-free survival for completely resected patients had a probability of 74%. Now, coming towards the overall survival in terms of grades, which looked something like this. A total of 31 patients died, 17 in the high grade, 17 in the intermediate grade, and 7 in the low grade. As this Kaplan-Meier curve depicts, high-grade patients had a median overall survival of 8.4 months, whereas median overall survival for intermediate and low-grade patients was 58 months. In the 5-year overall survival window, low-grade patients had a survival of 88%, intermediate grade had a survival of 57%, while high-grade patients could not reach the overall survival window of 5 years. On the other hand, grading-based endpoint in disease-free survival was disease progression. A total of 10 patients had disease progression, 5 in the low grade and 5 in the intermediate grade. And this Kaplan-Meier graph shows the median disease-free survival was 33 months. Please remember that only 3 patients had surgery in the high-grade group, making the number extremely small. Hence, we could not calculate disease-free survival in high-grade patients. So now coming towards the conclusion, we can say that overall survival and disease-free survival have proved to be high in the presence of resectable disease and low-grade JEPNETs, which can act as potential predictors of JEPNET outcomes. Thank you. If you have any questions, I'm happy to answer.
Thank you, Dr. Aisha. Again, excellent presentation. Just wanted to ask, your patients had any kind of a medical treatment in the form of any drugs, any targeted treatment, any chemotherapies as well or not?
Yes, they did have, but we did not look at that. We looked at the resection, the resection and other clinicopathological features, but some of the patients, they did have chemotherapy.
Okay, thank you. So our next presentation is again from Dr. Verda Beg from Shaukat Khanum Hospital, and she'll be talking about synchronous primary endometrial and ovarian cancers, trends and outcomes.
Congratulations.
Dr. Verda.
Yes, thank you, sir. I'm Dr. Varda, resident general surgery at Shaukat Khanum Hospital, Lahore. Can I please have my presentation? Thank you. So I'm going to talk about synchronous primary endometrial and ovarian cancers, the trends and outcomes of this rare disease at South Asian Tertiary Care Cancer Center. So this study was done to evaluate the clinicopathological behavior, the treatment modality related outcomes and prognosis of this rare entity. Let me tell you that the synchronous ovarian and endometrial cancers, they comprise of only 0.5% of all the gynecological malignancies occurring in women. And we made a comparison between synchronous endometrial and ovarian malignancies as opposed to the primary ovarian and primary endometrial cancers. It was again a retrospective study, a case series of 30 patients that we received over a period of 12 years. This goes on to say how rare this disease is. So within 12 years, we could only find 30 patients who were diagnosed histologically by an expert panel of pathologists here at Shaukat Khanum, and they followed the WHO criteria for the diagnosis. We took the data from cancer registry database at Shaukat Khanum Hospital, and it was analyzed using the SPSS version 20. So looking at the data of these 30 patients, we saw that younger patients were only 36.7%, and above 50 years of patients, 63% of them, they developed this disease. The median age of our population was 51, plus or minus 11.9 years. And the BMI, this is an interesting finding, BMI greater than 25 was found in 67% of the patients. We also collected data regarding the presenting complaint of the patients, and the most common presenting complaint was irregular uterine bleeding, followed by abdominal pain and postmenopausal bleeding, competing at 8 number of patients basically, and abdominal mass. The abdominal mass presentation was because of the ovarian pathology, whereas irregular uterine bleeding happened because of endometrial synchronous cancer. So we looked at both the cancers individually. Looking at endometrial cancer, we found that grade 2, histological grade 2 was the most common, occurring in 14%, 43% of the patients. Early stage of the disease was found in the endometrial group, the S1 stage, in 70% of cases. Lymphovascular invasion was not found in 83% of the cases, which means that we were able to catch this cancer early on. And it happened because of postmenopausal or irregular uterine bleeding and patients presenting with that concerning symptom. The depth of invasion was not known in majority of the cases. Looking at the the ovarian variety of cancer, grade 2 again was common in 40% of the patients. Stage 1, again, like the endometrial counterpart, was present in 73% of the patients. This was actually helped by the irregular bleeding produced by the endometrial cancer occurring simultaneously. And lymphovascular invasion, again, was not found in 83% of the patients, which is a good sign. We also looked at the histological variety of cancer present. In 83% of the cases, the endometrium had adenocarcinoma. This is the most common variety we found in our patients. High-grade serous carcinoma was present in 13%, and undifferentiated endometrial sarcoma was present in 3% only. Looking at ovarian, again, the endometrioid adenocarcinoma, which was present in the endometrial part as well, was found in 83% of the cases. Mucinous cystadenocarcinomas was found in 16%, and Brenner's tumor was found in 16% of our patients. For treatment, surgical intervention was our cornerstone. However, only 4 patients, they underwent induction chemotherapy, neoadjuvant, before the surgery. All of the patients, all 30, they underwent surgery, either having a total abdominal hysterectomy or bilateral bilateral salpingo-oophorectomy. This combined with omentectomy and appendicectomy in 3 of the patients, and TAH-BSO along with pelvic lymph node dissection was done in 10% of 10 cases only, the ones who actually were node positive. 18 patients went on to have radiotherapy as an adjuvant therapy. So our survival analysis based on categorical variables. This is where our study actually becomes interesting. We saw that patients younger than 50 years, they had a 5-year survival rate of 63%. And the patients above 50 years of age, they had a survival rate of 85%. But looking at the p-value, and the p-value is not significant as we did not have a large enough group to study, we cannot with confidence say that these findings held true. The the menopausal state also depicts this incoherence, that premenopausal patients who are expected to be younger, they had a short survival rate as compared to the postmenopausal patient. But again, the p-value does not, make these results significant. The multiparous patients, they have a better survival outcome as compared to nulliparous patients. This is actually a finding consistent in international studies as well. This also goes on to explain some role of hormones in these synchronous endometrial and ovarian cancers. And another finding that patients having BMI of less than 25, thinner patients, they had a better survival outcome as compared to their more obese fellows. So in our study, we see that overall 5-year survival rate was 75%. And we can optimize the care and understanding of this disease based on our study. The earlier age of onset kind of dictates the role of hormones in our patients, and the finding that nulliparous patients with greater than 25 BMI patients, they had a worse survival outcome, goes on to say something about the hormonal effects of the female hormones or on the genital cancers. We can improve the study by comparing the data from primary diseases, the primary diseases which had developed METs in other organs and synchronous diseases directly, to see if the difference is significant. We can also compare our data with international data to see if our results were consistent. We also can explore the role of possible molecular pathways and go on to find some targeted therapies to improve the survival outcomes in our patient. However, when we compare the synchronous genital malignancy with primary malignancies, the patients having synchronous disease, they do well, especially better than the ovarian cancer patients. That's all from my presentation.
Thank you, Dr. Varda. Excellent presentation, and we hope to see all those changes which you've already suggested next year, inshallah.
Thank you.
So our next presenter is Dr. Saad Malik from Khan University, and the topic of his presentation is readmissions due to venous thromboembolism after complex cancer operations and analysis of a national data set.
Assalamualaikum. Can you hear me?
Walaikum Assalam. Ji, we can. Yes, we can see. Yeah,
Okay.
that's better now. Yeah.
Okay. So my topic was readmissions due to venous thromboembolism after complex cancer operations. It was an analysis of a USA national data set. I'm a third-year medical student from the Khan University, and my co-authors were Dr. Nabil Wasif and Dr. Nabil Zafar from the Mayo Clinic and MD Anderson, respectively. Okay, so VTEs defined as like pulmonary embolisms and deep vein thrombosis are a major cause of preventable morbidity and mortality after cancer surgery. A lot of studies have shown that over a third of VTE events occur after discharge in post-op cancer patients, and some of them can be serious enough to warrant hospital readmission. However, there's limited data on how many readmissions we see. So we aim to determine the rates, outcomes, and predictive factors and costs that are associated with these readmissions. And we looked at 30-day, 90-day, and 180-day readmissions using a national data set. So initially our goal was to do this using Pakistani data, but unfortunately due to a lack of publicly available national data set that tracks multiple hospitals, we opted to use the 2016 US nationwide readmissions database. Basically this collects data from hospitals in 25 states and follows 11 million patients across 17 million visits annually for a wide variety of conditions. So we selected adult patients who underwent either cystectomy, colectomy, esophagectomy, gastrectomy, liver biliary resections, lung bronchus resections, pancreatectomy, proctectomy, prostatectomy, or hysterectomy for corresponding cancer diagnosis. So we used ICD-10 procedural codes to select our patients, and then we ensured that they were getting these surgeries for a cancer diagnosis that corresponded. We removed patients who had chronic pulmonary embolism or chronic DVT in their patient records. And so the total patient number ended up being 126,104 patients. So the 30-day readmission rate we saw was 0.61% and 1.07% for 90-day readmissions, and 180-day readmissions was 1.74. Generally across the board, PE readmissions were bigger factor than DVT readmissions. And if we specifically look at the outcomes during these readmissions, the median length of stay when someone was readmitted was 4 days. Non-index readmission was 32.64%. And by that, I mean admission to a hospital that wasn't the index hospital, so a hospital where they didn't have their cancer surgery. Mortality rate seen was 5.11% during readmission. And the total hospital cost for patients readmitted for VTE in 2016 for these hospitals was $25.6 million. And if you look at this graph, it shows like the difference between the different rates you see in different surgeries. So the highest was seen in cystectomies, where it was 3.28%, followed by pancreatectomies, which was 3.14%. And then the lowest readmission rates were seen in prostatectomies, which was 1.12%, and lung and bronchus resections had 1.33% readmission rates. And one of the key things to note in this that we were surprised to see was you can see there's a difference in rate. Many of surgeries after 30 to 40 days showed a marked increase in the rate of readmissions, like for example, pancreatectomies, whereas there's other ones that would start off as high and then taper off like prostatectomies, and where the rate would stop going up after around 50 days or so. Then we also use multivariate regression to find factors associated with 90-day VTE readmissions. And what was significant was if in cases for age, people between 75 to 84 had a 30% higher chance of getting readmitted. Females had a 23% higher chance. People using private insurance had a 20% lower chance of being readmitted. Non-elective emergent admissions, initial admission, so at the time of surgery, would result in 31% higher chance of being readmitted with VTE. And then 61% for procedures themselves, 61% of colectomy patients, you had a lower chance of 61% lower chance of being readmitted for VTE if you had colectomy, 43% for esophagectomy, 46% for liver biliary resection, 53% for gastrectomy, and 45% for hysterectomy. And the comorbid score is basically used Elix-Hauser comorbidity score, which depending on how many comorbids and which comorbids patient has, it adjusts, it gives the patient a comorbidity score. The higher the score, the sicker they are. So as that increased, that also resulted in a higher VTE readmission rate. Okay, so conclusions and future actions. So readmissions due to VTE continue to increase well beyond 30 days after surgery. Most studies that have been published show follow patients only for 30 days. We followed them for 180 days to see that if the rate continued to increase, which it did. And another key finding was they occur frequently at non-index hospitals. So many times the readmission rates that are reported are lower because hospitals are tracking patients within their own hospital, whereas it's common for people to be transferred to other hospitals or have their surgery done at different hospitals. They also bear significant mortality and cost burden. High-risk patients would likely benefit from extended VTE prophylaxis. There's a case to be made that we can have risk profile development. When we further looked at our data, there was very a few risk profiles that we could develop. For example, people who were getting pancreatectomies, females who were getting pancreatectomies who were over 40 had like a 30% higher chance of mortality during their readmissions. So these patients can be monitored closely and maybe have continual VTE prophylaxis. And in terms of future directions, there's a limited number of national studies in Pakistan that look at outcomes after major cancer surgery. I think one of the main reasons behind this is because we have a lot of data sets within our own hospitals, but they're not shared across different institutions. There's a case to be made that we should have these types of studies done in Pakistan, and sharing of data should be more open. The strength of the study was it looked at a diverse national data set of over 17 million patients. And we had complete follow-up data, demographic data from all these multiple hospitals in these states. So we could capture things like non-index readmissions. The limitations were it didn't capture people who had mild VTE, who might have come to clinics, but maybe weren't in need of admission. And yeah, that's it from my side. Thank you.
So Dr. Saad, again, a well thought through and excellent presentation and well thought through study as well. So I wanted to ask, did you look at that all those patients did had DVT prophylaxis as well, and what type of kind of guidelines they were following? Because there is a bit of variation in the context of DVT prophylaxis being used.
No, great question. So the reason why we didn't look at this is we didn't look at outcomes of patients who had prophylaxis and followed them. One of the reasons behind that was since that data set is limited to 2016, patients